So thanks very much for asking me to speak today. This is a topic that's really near and dear to my heart, working as a pharmacist in the Geriatric Day Hospital at Bruyere. I see a lot of patients that are confused or having falls that are quite often related to their medications, and they improve significantly when we reduce doses and stop medications. So deprescribing is something that that I've been doing without calling it that necessarily since 1999. Today, what I want to do is touch on some of the recent CIHI data that came out about 2 weeks ago to give you an update on drug use in Canada, talk about a systematic review of deprescribing studies that was published a couple of years ago, and then update you about what we're doing at the Bruyere Research Institute in terms of deprescribing guidelines, and also give you a bit of an overview of the Canadian Deprescribing Network. And I know that there may be some audience members that this topic is also newer for them, so I've also incorporated a little bit of background information about deprescribing. So I have no conflicts of interest to declare. I haven't found any commercial pharmaceutical companies that want to sponsor talks in deprescribing. So I do have a bias, however, and my bias are my patients. And I've sometimes been called the anti-pharmacist because I'm always trying to stop medications, and so sometimes I need to be careful about making sure that I'm also looking at the benefits or the potential benefits that they are receiving as well. So just to give you an idea, this is a typical patient medication list in the day hospital. This was a list of a patient that was admitted in January, and you can see the drugs that jumped out at me were the concomitant use of the clonazepam, trazodone, mirtazapine, risperidone, and hydromorphone, as well as the ranitidine, which can also have some anticholinergic effects. So this is the sort of thing that I'm typically faced with, and I think a lot of family physicians are faced with as well. We often get referrals to the day hospital for polypharmacy, especially from family physicians who've maybe acquired a new patient that is an elderly patient and has a medication list like this, and they're not quite sure where to start in terms of deprescribing. So what I'm going to do is just go over a bit of the concept process of rational deprescribing, talk about the potential benefits and harms from the systematic review, review some of the barriers enablers of deprescribing, and then summarize successful approaches in our ongoing research. So just to put this out on the table, I do know that medications can have positive effects. They can obviously treat symptoms, anxiety, pain, heartburn, etc., slow the progression of disease, and reduce the risk of complications from disease used in a preventive way to, for example, reduce the risk of future heart attacks. So the problem is that we see many Canadians, and this is reflected around the world really, taking more than 5 or even 10 medications. The CIHI data that was published 2 weeks ago, and this is a great report to read, the drug use among seniors on public drug programs in Canada, and it's the full report is available on the CIHI website, shows that these numbers haven't changed in the last several years. We still have about 2/3 of Canadians that are taking at least 5 different prescription medications, and that's how we used to define polypharmacy, was taking 5 or more medications. We know that about 1/4 of Canadians over 65 are taking at least 10 different medications. And one of the interesting figures that comes out from that report is that about 40% of people over 85 are taking at least 10 medications, and 66% of patients in long-term care are taking at least 10 medications. So these are the sorts of patients, the over 85, the ones in long-term care that are very frail, that we actually don't have a lot of information about the benefit, especially in terms of the preventive, like what complications are we actually able to prevent for these patients, or has drug-related morbidity kind of taken over in terms of potential harm. So this chart from the CIHI report illustrates that the number of drug classes prescribed to seniors increases with age. And I'll draw your attention to the bars on the far right for the groups taking 15+ medications. And this shows that about 10% of those over 85 in Canada are taking over 15 medications, compared to about 5% in the 65 to 74 age group. There's also variation across Canada, and often this variation can be attributed to differences in the population in the different provinces, sex, age, general health, and also the public drug program design. But this kind of breakdown from CI-HI is very helpful for also understanding the implications of different policies. And in the report itself, there are charts showing the distribution of specific drug classes. So for example, PPI use, so proton pump inhibitor use, is much lower in BC, where a physician has to actually complete a special authorization form in order to prescribe a proton pump inhibitor beyond 8 weeks. So this kind of data allows us all to look at the implications of those policies. Hospitalizations due to adverse drug reactions is an issue for roughly 1% of Canadian seniors, but when we look at the risk factors for those hospitalizations, the key one that is most responsible for adverse drug-related hospitalization is the number of drugs that are prescribed to seniors. It's not the number of pharmacies they go to or the number of physicians they have or their sex or their age. It's related to the number of drugs. And it's costing us a lot of money. So this report was published by Steve Morgan in the Canadian Medical Association Journal 2 years ago. It's also a really helpful paper to read and is very helpful if you're trying to get research funding to look at this problem. This is a good paper to reference. What he did was he looked at medications, particularly those that are considered potentially inappropriate. He used the Beers list, which is an American consensus-developed list of medications that are risky in older adults, and then looked at which seniors in Canada were taking those medications and calculated the approximate annual cost for that medication and determined that we are spending about $420 million on potentially inappropriate medications. This data was from 2013. And then he estimated in terms of the adverse drug-related hospital admissions that might occur from using those medications, so falls particularly and hip fractures, which are very expensive, and estimated that the use of those medications could account for almost $1.5 billion in incremental healthcare expenditure. So as I said, polypharmacy used to be, we used to think about it as the number of medications, and that's been more challenging in recent years as guidelines have recommended several medications for each chronic condition. So by the time you have 3 chronic conditions, you can easily be taking 12 medications. So we think of it more now as taking more medications than are needed, or for which harm outweighs benefit. And there's many studies that demonstrate that this increases the risk of adverse drug reactions, drug interactions, falls, fractures, functional cognitive decline, non-compliance, and when I say that, I mean intentional non-compliance as well, which is actually more of a problem than simply forgetting to take your medications. It's not wanting to take your medications because you're sick of taking your medications, or, as I've heard some patients say to me, that they're taking so many medications, and I once had a patient who took 60 pills in a day, that she wasn't hungry to eat food because she was taking so many medications. And of course the hospitalizations and higher healthcare costs. And it's particularly problematic for the older elderly and the frail elderly who handle and respond to drugs differently and are not represented, as I said, in research. So as we get older, the brain becomes more sensitive to drug side effects, so benzodiazepines and opioids particularly. And this kind of explanation is really helpful to explain to patients why you might be concerned about a drug now when they're 85, but you weren't concerned about it as much when they were 62, when they first started taking it. And particularly this is helpful when I explain about benzodiazepines to older people, why we might want to reduce the dose because the brain becomes more sensitive to the side effects. Some medications stay longer or are distributed differently because we have less muscle, more body fat. So a drug like diazepam, for example, which is very fat soluble, will stay much longer in the body. Liver and kidneys don't process medications as efficiently. We tend to think about renal function as the only important method of excreting a medication from the body, but we also need to think about the liver, and particularly the liver mass mass reduces as you age and the blood flow reduces. So this has a couple of different effects. First of all, a drug that typically has high first-pass metabolism, so metoprolol, which would normally get metabolized as soon as the blood flow hit the liver from being absorbed in the stomach. If it's not getting metabolized, then you're actually getting a much higher initial blood concentration than you would have if you were younger. And then as well, you're not able to excrete it as fast because you're not metabolizing it to its inactive form. So this is why we worry about some drugs like beta blockers, which tend to really build up over time. And also, again, because we have less water as we get older, some medications become more concentrated, and the standard example of that is digoxin. So when I'm faced with a patient in the day hospital who has a symptom, whether it's incontinence or cognitive impairment or falls, the first question that comes to my mind is what drugs might be causing this problem. And there are many lists of medications that can contribute to problems like incontinence, memory, and falls. And the one I want to point out here that I think is one that we don't often initially see because it's not a prescription drug is the patients who are taking things like Nitol and NyQuil or Tylenol nighttime, because those all contain diphenhydramine, which can be quite anticholinergic and can affect memory and cause dry mouth. This is a slide from the Canadian Deprescribing Network, and what I like about it is that it presents the variation in risk from different groups of medications. And I think, we pick on benzodiazepines all the time without necessarily realizing that antidepressants also increase the risk of falls, and therefore it's so important to make sure that the benefit or the potential benefit of the medication outweighs the risk. And so we at the day hospital do a lot of tapering of antidepressant medications as well with care, and it's great for them and for us because the patients are coming 2 days a week to the day hospital for a couple of months, so we can evaluate the impact of those dose reductions. And as well, the risk of drug interactions obviously increases the more medications that you're taking. So deprescribing, we define that as the planned and supervised process of reducing or stopping medications that may no longer be of benefit or might be causing harm. And that's a little bit different than how some other countries are defining deprescribing. In Australia, for example, they define it only as the complete stopping of a medication. But we have seen in our practice in the day hospital, and it makes sense when you think about the increasing sensitivity to the side effects of drugs, as well as the changes in metabolism and excretion, that you can often improve symptoms by reducing the dose and still obtain the benefit of the medication. So when I talk to patients, I usually just say it's really just part of good prescribing. It's about backing off when the doses are a bit too high or they become too high over time, or stopping medications that might no longer be needed or might be causing harm. And I'm sure many people have seen the patient who, when you ask, tell me about this medication and how it's helping, and they say, well, I don't know why I'm taking that. And then you say, well, what did the doctor tell you when they first prescribed it? And they say, oh, I can't remember, it was 1963, and it was Dr. Smith. He's dead. And so it's, we often have so little information to judge this, whether or not the medication is still needed. So it's, it takes, I think, some hope and optimism when you're trying to stop a drug, because you don't want to cause harm to the patient by stopping the drug, but you also don't want to cause harm by continuing the drug. But sometimes changing something can be difficult. And this is what we're trying to balance when we are deciding whether to continue or stop a drug. On the left-hand side, in terms of benefit, we've often got evidence for the initial reason for the drug, or sometimes we have evidence for the initial reason for the drug. And we might have some evidence for effectiveness, or there might have been some evidence initially. But over time, we have the age-related changes, we have the additional comorbidities, which mean additional medications, additional risk of drug interactions, et cetera, or people might have developed a side effect, or we might suspect that that drug could be contributing to a side effect. So the risk increases. And over time, people's goals and values change as well. And the goals, hard goals, I think about A1C targets or blood pressure targets changing in terms of age and frailty, and also time to benefit. So if the patient is near end of life, does it make sense to start a medication that takes 3 years in order to get a benefit? So having conversations about the risk and benefit and the goals and what are the patient's values and what are the family's values, I find is very time consuming, and I think is probably one of the major reasons why it doesn't happen more often in practice. In terms of the steps, these steps have been compiled from a literature review that Emily Reeve did and published in 2014 of all of the different deprescribing algorithms and processes that had been published to date, and really distilled them into 6 steps. So initially compiling a complete medication history, so including those non-prescription drugs as well. Identifying those that are potentially inappropriate, and there's a variety of ways you can do that through using the Beers criteria, the STOP criteria, looking for anticholinergic burden, and then also looking for those with less evidence for benefit or those that might be causing harm by asking that question about could this particular symptom the patient has be caused by a drug. And then assessing each of those medications for eligibility for deprescribing, prioritizing them, and developing a plan for tapering and monitoring of each of the medications, and then monitoring the actual deprescribing effects, providing support, and documenting care. So it looks easy, right? It's not. It's very time consuming, and one of the things that we wanted to do in our research team is to try to provide class-specific information that would make following these steps easier, because there were a lot of generic type algorithms published at the time, but not so much class-specific information about deprescribing available. So in terms of the potential benefits and harms of deprescribing, these are partially summarized from the systematic review that I'm going to talk about in the next slide, and partially also from my own experience. So in terms of the benefits, we can improve adverse effects that might be happening, and we've seen this with cognitive impairment, falls. Also, really quality of life affecting symptoms like diarrhea, where this can sometimes be 2 or 3 medications that might be contributing to that, and we reduce or stop them, and the patient's symptoms improve. Reducing the risk of drug interactions, reducing pill burden and cost. And of the deprescribing studies that have been published, most of them have shown the ability to reduce the numbers of medications prescribed, or the pill burden, which is really the number of pills they have to take during a day, and decreasing costs. We've actually had several cases in the day hospital where, after stopping a number of medications, people's diagnosis of dementia has become more questionable, and their cholinesterase inhibitor has been stopped because their confusion has cleared. Fewer falls, and the deprescribing studies that have had falls as an outcome have not demonstrated a cessation in falls through deprescribing, but in the groups where deprescribing occurred, the number of falls has significantly reduced for those patients. Improving quality of life, less delirium, fewer emergency department visits and hospital days. These are potential benefits that haven't necessarily been shown in randomized controlled studies yet. Improved compliance, we see that as an outcome in the day hospital quite often. The less pill burden a person has, the more likely they are to take the remaining medications, especially once they understand that they're only now taking the ones where we know there's definitely benefit. Less daytime fatigue when we stop sleeping pills, obviously. Less ankle swelling. So we see, this is probably the most common prescribing cascade we see, where people are on either amlodipine, pregabalin, gabapentin, drugs that cause ankle edema, and then they end up on Lasix. to deal with the ankle edema, but they don't really have another indication for the Lasix, and then the Lasix causes orthostatic hypotension, and then they have falls. So we start by stopping the amlodipine, the pregabalin, the gabapentin, and then gradually the Lasix while carefully monitoring in order to affect ultimately falls. And yes, eliminating prescribing cascades is a big benefit. In terms of harms, you can have the symptoms of the original disease come back. So you might be stopping an NSAID and their pain returns. You can have some physiological harms. So this might be, for example, if you're stopping a PPI and they get rebound heartburn because they have some excessive acid production. And you can have new discontinuation type symptoms occur. So SSRIs are a group of drugs that have a distinct discontinuation syndrome that you need to be familiar with to monitor. And you might lose some benefit, or you might unmask a drug interaction. And that's something that we need to be very careful about monitoring to make sure that when we're reducing the dose or stopping a drug, that we're not affecting the benefit or harm of another drug. So this systematic review was published in 2016, and the previous systematic review on trials of deprescribing have been published in 2008. And there's some difference in terms of what these two studies report, but this particular one I think was very helpful because it showed that in the non-randomized studies, there were 132 papers they looked at altogether, deprescribing polypharmacy significantly decreased mortality. However, that was not borne out in the randomized studies, and so that is something that some of the authors of this particular review are currently trying to work on, is a randomized study for deprescribing, which in some cases seems challenging from an ethical perspective in terms of randomizing someone who might then continue on a drug that might be harmful. The subgroup analysis was helpful because it showed that the patient-specific interventions to deprescribe demonstrated a significant reduction in mortality, but a generalized education program did not. So for example, we're not going to expect that all of you are going to have an effect on deprescribing just by listening to this presentation. But you are going to have an effect if you go out and you do a medication review that is patient-specific for a patient and you help them deprescribe. So that's going to be your homework when you leave. So I mentioned about monitoring for harm from deprescribing, and this is what I think most people are worried about. And I remember when I started at Briere in 1999 and started asking questions about, do you think we could stop this? A lot of times people would say, oh, I don't think we should rock the boat. The patient's really stable right now. And I'm thinking, well, they got referred because they're having falls and cognitive impairment, so I don't think they're really that stable. But there was sort of this inertia about it, but also a fear of what might happen if you stopped the drug. And the classic one is, if I stop the PPI, will the patient have a GI bleed? Which, might occur if they were taking the PPI because they'd had a GI bleed and they still had risk factors for a GI bleed, but probably wouldn't occur if they were taking it for heartburn. So the signs and symptoms that we want to monitor are those physiological rebound type symptoms, monitoring for symptoms of return of the underlying condition, and the new symptoms, as I talked about, the discontinuation types symptoms. And they are more common the longer the patient has been taking the drug, taking higher doses of the drug, taking drugs that have a short half-life. And I would say that's really, those conditions are really relevant, especially in terms of benzodiazepines. And if they have a history of dependence or abuse, that's very challenging, of course, with opioids and benzodiazepines. And one of the reasons why it's very hard to, say, develop a deprescribing guideline for opioids. And a lack of patient buy-in has been shown in these adverse drug withdrawal studies to increase the risk of adverse drug withdrawal. And I'll talk a little bit about patient engagement and buy-in in a minute. So in terms of challenges and enablers, there have actually been two systematic reviews published on this topic. One looking at studies of prescribers in which The summary really highlighted that the challenges were maybe a lack of an awareness or insight into their own prescribing practices, this sense of inertia, not wanting to rock the boat, some challenges with self-efficacy, not knowing how to identify which drugs should be deprescribed or which drugs might be contributing to a symptom the patient had, not knowing how fast to taper. And this is a sort of common question that I get. I've been doing the polypharmacy workshops with physicians and pharmacists over the last 4 or 5 years, and the most common questions are, how do I stop the drug? How fast can I stop the drug? What do I need to monitor when I stop the drug? And so I think people need that information in order to feel more confident. The feasibility, and when you looked at all of the steps involved in deprescribing, it's very time consuming, so how feasible is that in a family practice in particular, or in a short hospital stay? That's the other challenge. If you're only here for 4 or 5 days, is it really feasible to go through all of those steps with the patient? And devolving responsibility is a big issue. You know, it was the specialist who, in the hospital, who prescribed that, so I don't want to stop what the specialist started. And sometimes if you've got a patient who's got a family doctor and 3 or 4 specialists, and they're all prescribing independently, and the family physician is kind of nervous about stopping other people's medications, it becomes really challenging for the patient. And that's the complexity around prescriber complexity, but also the challenge around patient complexity and not knowing really who's taking the overall responsibility for making sure that those medications don't have the additive side effects and the additive drug interactions. And then the last one is the issue of treatment guidelines. And put up your hand if you've ever seen a treatment guideline that tells you when to stop the drug. Never. So that was a big issue and one that kind of spurred our research on. In terms of patients, this is the second systematic review. Patients are really hypothetically willing to stop a drug if their physician says you should stop this drug. And they're often very interested, and I know this both from a personal perspective, 99.9% of the time when I say to a patient, what questions do you have about your medications? They say, what can I stop? Or why am I taking so many? So they're very interested in trying to reduce their medication burden. And there have been, Emily Reeve has done a survey with patients about this as well. That's the third reference here. They're affected by their belief in whether or not the drug was appropriate in the first place. So what education was provided to them initially about the purpose of the medication or whether they saw benefit from the medication. They are also affected by the fear of stopping a medication. What will happen if I stop the medication? They're influenced by their family doctor, their family, their friends, the media. Previous experience is a big one. So, I tried to stop taking my Ativan a couple years ago and I couldn't sleep the next night, so I figured I needed to take it forever. Which, when you understand that the insomnia withdrawal reaction is typically 3 or 4 days, and then you return to a normal sleep pattern, when people have that piece of information, they are often more successful in deprescribing. And many patients just dislike taking medications. These are ones who are probably not taking the medications in the first place. Those are the easiest ones to deprescribe if you find out they actually aren't taking it. And then knowing that there's a process. So that was a big one, and I think why in our definition of deprescribing, we include this information about the importance of having a process for deprescribing that is both supervised and also understood and agreed to by the patient. So we often will decide on our tapering schedules based on how fast the patient wants to taper or how comfortable they feel reducing the dose of the medication. This is the influence of media. So this, I think, is a 1960s ad for physicians about prescribing oxazepam. You can't set her free, but you can help her feel less anxious. I feel like Trump's staff should all be taking oxazepam. So in the 70s, the benzodiazepines were the most prescribed medication in the world, and they still are in the top 10 medications prescribed in Canada. In fact, this Kai-Hai report has a great summary of the top 10, and I think 3 or 4 of the top 10 are PPIs, and a couple of them are benzodiazepines. Women are generally more frequent consumers, and that is also borne out in the CIHI data. You see that more women take more potentially inappropriate medications. So in terms of what Canadians currently think about deprescribing, this was a telephone survey that was published by Justin Turner and Kara Tannenbaum from the Canadian Deprescribing Network last year, and they did a telephone survey with 2,665 Canadians over the age of 65, and they found about 65% were familiar with the term drug-induced harm. Almost 50% had actually done some kind of research into medication-related harms, but only 7% actually recognized the term deprescribing. But they were able to show through their analysis that patient-initiated deprescribing conversations with their physicians, so where patients said they had gone to their physician to talk about to talk about deprescribing, were associated with awareness of medication harms, familiarity with the term deprescribing, and information-seeking behavior. So their conclusion was that if physicians started to use the term deprescribing more often, that patients would begin to understand that that was an option to deal with medication-related harm, and that that would be a beneficial thing. So I'm going to take you back now, because a lot of the studies that I have talked about were published in 2013, 2014, 2016, 2017, but we were thinking about this issue of polypharmacy and deprescribing at about the same time that all of those researchers were doing their work to start those systematic reviews around polypharmacy and deprescribing. And the issue at Briere, of course, was that we had had a decade of seeing all these patients taking more medications all the time, and trying to understand ourselves why that was. And the issue that commonly came up from physicians was that the guidelines tell you when to start drugs, but they don't tell you when to stop drugs. So we had this conversation in the hallway one day and said, wouldn't it be great if we had deprescribing guidelines? And so that is what we set out to do. And we got funding in 2013 to develop deprescribing guidelines, and we thought, well, to make these credible and valid, we don't want to just make another algorithm that we think up on the back of a napkin over lunch. That we wanted to actually try to develop deprescribing guidelines using a very systematic method, the same kind of method that people would use to develop a prescribing guideline. We also didn't want to get pushback from the pharmaceutical companies, so we wanted to make them as evidence-based as we could. So this is an overview of what we did over the next 3 years. We talked first about carefully identifying the priorities for the deprescribing guidelines. We got funding from the Government of Ontario to work over 3 years. So we're going to develop 3 guidelines. So we did a Delphi survey. And then we established a guideline methods committee, and we were lucky to have Dr. Kevin Potty in the city, who had been very involved in the Canadian Task Force on Preventive Guidelines and was a member of the grade committee. And so he agreed to join us to help us put together the methods for the guidelines. And then we developed each guideline one at a time. And after we developed each one, we tested it in long-term care and family health teams in Ottawa. And this was kind of something new that Kevin said people don't normally test a guideline with the potential users before it actually gets published. So we did that for each of the 3 guidelines one at a time, so that we would learn about how to improve our methods for developing the guideline as well as implementing it. And we collected primarily qualitative information because we were really interested in the processes of how we developed the guidelines and how we could improve that or make recommendations to others, as well as how we could implement them and make recommendations around implementation. So this data is from our priorities paper. So we conducted the Delphi survey. These were the top 10 drug categories identified by 65 Canadian geriatric experts. And so we had geriatricians, family physicians, pharmacists, nurses that participated, that were specifically targeted because of expertise in geriatrics. So The topics that we picked to develop guidelines for were the benzodiazepines, antipsychotics, and the PPIs. We still get lots of pressure to develop a guideline for statins, but we did a scoping review, and at the time there weren't any deprescribing studies. And I'll demonstrate to you in a second why we needed deprescribing studies in order to develop the guideline. So each of the guidelines are class specific. They're developed using AGREE-2 and GRADE. We developed the three initially: PPIs, benzodiazepine receptor agonists, antipsychotics, and then subsequently we got some funding from CIHR to develop one for antihyperglycemics. And they each address for whom deprescribing is appropriate, when and how to deprescribe, what to monitor and how often, and what to do if symptoms recur. So basically, these are trying to answer all the questions that physicians kept asking us whenever we did workshops. And because we're using the GRADE process, they automatically include the consideration of patient engagement in the guideline development because making a GRADE recommendation requires that you do a literature review on patient values and perspectives around the topic. So this is our overall methodology for the deprescribing guideline preparation. We initially started by establishing our topics of interest. We developed a guideline development team. We were very purposeful in who we invited to be on those teams. So for example, the very first one we did on proton pump inhibitors, we invited Paul Moyadi, who was the chair of the Cochrane GI group. So we tried to get people who were influencers, the same way that clinical guidelines try to have people who are influencers in their guidelines. And then we defined the scope and purpose of each guideline, generated key clinical questions, which were really around the safety and effectiveness of continuing versus reducing or stopping the medication. We conducted a systematic review, and so these were basically a systematic review on deprescribing studies. So for the PPI guideline, for example, at the time there were 5 randomized controlled trials that met the criteria for a deprescribing study that we used as the systematic review. We then synthesized that information and also looked at additional information such as the benefits of continuing in the medication, the harms. So we did a review of harms in order to summarize the harm of continuing the medication. We looked at patient values. We also looked at resource implications of continuing versus stopping the medication. And we also looked at the other prescribing guidelines to see were our recommendations consistent with their recommendations, say, for set duration of treatment. And then we formulated the recommendations, assessed the strength using the GRADE approach, added clinical considerations. So these were around things like how fast can I taper? And that was partially drawn from the studies, the deprescribing studies, but partially also from personal experience, and then partially from the clinical and stakeholder review that was then completed. What we kind of realized at about this time was that each of these guidelines was going to be 5,000 to 7,000 words long, and that no one would probably ever read them. So we thought we need to have a tool that people can use that they can see the summary of this very quickly, and so that's why we came up with the algorithms that you see that are based on each of the guidelines. And we then piloted them and incorporated the implementation site feedback into the algorithm and the guideline where it was relevant. So all 4 of those guidelines have now been published in Canadian Family Physician. They're all open access so that you can get all of the information, including all of the detailed search strategies and the systematic review results. And they're available in French and English, which is awesome. So on the left here, you can see an example of the algorithm for people who are here in the audience today. I've got a binder at the front of the room. I've got hard copies of all of these algorithms and tools, but they're also available on our website, deprescribing.org. So we've got the algorithms that follow the step-by-step process. We've got corresponding patient pamphlets, because that was some of the feedback we got in the implementation sites, was that the prescribed prescribers wanted information they could hand to the patient or the family that would help them understand the rationale for deprescribing. And then on the right-hand side, you see an infographic, which is a bit like a poster that you could put in the window of a family physician office or a pharmacy to advertise, to help people to come to you and talk about deprescribing. So what we've been doing with our team, and this is just a quick overview of what we are trying to do, is we're trying to provide healthcare providers with these evidence-based guidelines and algorithms to help them decide when and how to reduce medications. There's a fifth one that's now been developed for cholinesterase inhibitors, and that was developed by a postdoc from Australia who has spent the last 2 years working with ourselves and Ken Rockwood in Halifax, and that is, you can also get to it from deprescribing.org, but it's actually published on an Australian website. And we are trying to spread the word by doing these kinds of presentations, reaching out to community groups. I did a similar presentation to this 2 weeks ago to the Canadian Association of Retired Teachers. We did a presentation about a month ago to RCMP retirees. So lots of community group education going on, and we're trying to do more in terms of engaging policymakers. So I've met with the Minister of Seniors, well, I guess the former Minister of Seniors Affairs in Ontario, as well as people in the Premier's office and the Ministry of Health to try to push the agenda forward in terms of eventually getting some sustainable funding. I guess we have to start over now. And we're trying to network, like today, with like-minded healthcare providers and organizations. And this is, it's, as Kelly was saying, it's a big movement, and it's getting bigger. And in the last 2 weeks, I've been to 2 conferences, the Canadian Pharmacists Association Conference in Fredericton and the Ontario Pharmacists Association Conference in Huntsville. And at both conferences had 1-hour workshop deprescribing sessions for attendees that were very well attended. So I know pharmacists are definitely interested in trying to help with this, and we're getting asked to speak to a lot of physician groups, and we now have a nursing subgroup at the Canadian Deprescribing Network that's interested in looking at how to incorporate these competencies into nursing curricula across the country. So in terms of our research program, we started with this first project in 2013. It finished in 2016. Then we had a small amount of funding from the Canadian Foundation for Pharmacy to look at the feasibility of having community pharmacists use some of these algorithms in their practice with patients and collaborating with physicians in their communities. So that is complete now. We're working on the paper related to that. We've got 2 grants that are knowledge mobilization type grants right now. One is through the Centre for Learning, Research and Innovation, doing stakeholder engagement and then spreading the different tools and resources and long-term care in Ontario. And we've got a CCABI Knowledge Mobilization Partnership grant around building capacity for not just use of the guidelines, but also use of the methodology. So we published a paper on the methodology for our guidelines, and through this funding, we've also created an instruction manual for guideline coordinators. So we are trying to make it easy for other people to develop deprescribing guidelines, and we are trying to push groups that develop guidelines to include sections on deprescribing. And so one example from this is that Kevin Potty, who is a member of the grade committee, has managed to establish a grade special interest group on deprescribing, and they're going to be having their first meeting in Manchester in September. We also, through that funding, hosted an international symposium in March. We had 130 people who do research and implementation work with deprescribing, and policy makers come from 10 different countries. And we met for 3 days here in Ottawa and moved the agenda forward a lot in terms of implementation and evaluation research. The next study is a fairly new one I'm working with Paula Rochon in Toronto. She's a geriatrician there on a CIHR grant where we're exploring prescribing cascades. So she and Andrea Grunier are doing more the quantitative, looking at using the ISIS database to look at combinations of medications that might implicate a prescribing cascade, and what we're doing here at Briere is we're doing the qualitative piece. So we are interviewing people, families, and the care providers of patients who have had a prescribing cascade happen to try to understand how the prescribing cascade happens, like why did no one, for example, identify that the ankle edema was caused by the amlodipine before they started the Lasix? And then we're trying to understand the development so that we can help to prevent those kinds of problems from happening in the future. And then the most recent grant that we have is another Government of Ontario Health Services Research Foundation grant, and this one is looking at implementing deprescribing initiatives, which may include use of the guidelines or may include some of the other resources using a community engagement strategy. And this was because some of the feedback that we got in our very first study from physicians was that, particularly family physicians, is that when patients come to them, it's not because they want to deprescribe something, it's usually because they have a new symptom and they're looking for something to be added to their regimen. And what they said was, if people came to us and said, I'm interested in reducing my medications, particularly this one I want to ask you about, that they would be much more inclined to have that conversation. So that's why we thought a community engagement approach might work. So we're going to be working with the community of Winchester on that. So very quickly then, we've done a lot of work in knowledge mobilization. You can see all of our tools on our website, links to our publications, links to our Facebook page, our Twitter account. I mentioned the symposium already, and some of the groups that we're networking with are listed here. We've had lots of uptake of these algorithms from the website. You can see almost 20,000 downloads for the proton pump inhibitor algorithm. We can measure what's downloaded from our website, but we don't have a good sense of how many other people are using the algorithms. This is a list of organizations that we know for sure are using the algorithms in some kind of study or on their website or as part of a toolkit. And I noticed actually going through the CIHI report, they've also got links to the algorithms in the CIHI report. Publication uptake has been good as well. You can see the citations are gradually increasing for each of these open access papers. We've created whiteboard videos using the knowledge mobilization money, so those are also available from our website, and we have a YouTube channel, deprescribing.org, if you want to watch any of these videos, which basically explain how to use the algorithms using a couple of cases. And our Twitter account has been growing, and I have a student this summer who's actually going to evaluate the use of the Twitter account in terms of establishing sort of a cognitive authority with respect to deprescribing. And you can see the countries around the world where we have followers. And we've got similar sort of data now for those YouTube videos as well, in that we know where people are watching the videos, which is really interesting. Lots of exhibits at public events. We'll add today to this slide as well. And then I know one of our team members is presenting with Geneviève Lemay, I think on Friday, at a geriatrics conference here in Ottawa. And because of the Knowledge Mobilization Grant, we're sort of churning out lots of tools, particularly translations. Now we've got funding finally to do French translation of our algorithms, our patient pamphlets, our infographics, and even the whiteboard videos. So that's happening as well. We still have a lot of challenges, particularly with the interpretation of the grade recommendations using the words like strong and weak, which have very clear definitions within grade and are outlined in each of the guidelines. And similarly, wording like low quality or low certainty, which are also part of the grade approach. But when users see that in the algorithm, they don't believe it's as credible. And so we have had some requests by people in other countries to remove that wording from the algorithms, and we've had to say no. And this has been one of our challenging as well. One of our challenges is the multiple requests that we get to modify the algorithm. So we have to keep going back to the fact that they're based on a published guideline, and we can't modify the algorithm except to sometimes replace what drugs are available in that particular country. But I have to say it's been a lot of work just dealing with requests for translation, modifications, et cetera. Attribution of authorship has been a bit of a challenge because so many people are using the algorithms now, Choosing Wisely, the Canadian Deprescribing Network, that sometimes it gets a little bit lost in terms of where they actually came from. Non-pharmacologic strategies, which we recommend, for example, as an alternative to benzodiazepine receptor agonist use, are sometimes costly, either in terms of funding, because cognitive behavioral therapy from a psychologist may be expensive, or costly in terms of time. Explaining sleep hygiene strategies to somebody, supporting them through that can be time consuming. So we often get a lot of requests to simply recommend a different medication, and this is reflected in the CIHI report. So for the first time, we've actually seen a decrease in benzodiazepine use in Canada from 2011 to 2016, from 17.5% down to 14% in people over 65, but that corresponds to a similar increase in the use of trazodone, which is problematic as well because it's anticholinergic. The best example I can give of that is I had a patient who was on 150 milligrams of trazodone at bedtime. The dose had been gradually increased, and so I said, well, what is the problem with sleep? Like, why are you waking up? Oh, my mouth is so dry. Well, trazodone causes dry mouth. So we stopped the trazodone, stopped the dry mouth. I know Kelly wants me to stop. Okay, very briefly, take a look at the website to find out some information about the Canadian Deprescribing Network, which is a group of us that are all focused on trying to help move this forward in Canada. And toward the end of the presentation, I've got a few of the infographics from the Canadian Deprescribing Network, which you can again get online. So they're producing a lot of great tools that you can use. And also take a look at the presentation slides to get some links to some different resources that you can use to educate yourself or to help to educate others around deprescribing. And maybe I'll stop there, Kelly. Sound good?
I think chance.
Thanks.